Hello, good morning, evening, or afternoon, depending on when you're watching this, but welcome to the antibacterial module. This is the first of two infectious disease-related topics you'll be getting from me. The next will be an antiviral, antifungal compilation, but today we'll focus on antibiotics or antibacterial agents. So, antibacterial agents are commonly referred to as antibiotics, so we'll use the term antibiotic throughout the course and throughout this lecture anyway. They're really the most commonly used group of drugs when it comes to infectious disease. The reason being is they're really effective. So we have the ability to kill bacteria fairly efficiently with the medications we have. Viruses and fungi, are not quite the same story. So when it comes to infectious disease and bacterial pathogens being very common, you're going to see a lot of antibiotic use for different indications. Basically, there's two major mechanisms of action, and we're going to kind of split it up. There's a couple other oddballs we'll talk about too. But antibiotics either work by inhibiting the way bacteria build a cell wall, so they disrupt the cell wall building process, or they work intracellularly to inhibit the protein synthesis, so that disrupts a major intracellular function of the bacteria. Most of these drugs are pretty well tolerated and can be used in a wide variety of patients, so that's always good. Talk a little bit about resistance and talk about renal clearance. Antibiotics, I think, from my experience in practice, a lot of providers forget about renally dosing on a lot of things, but antibiotics seem to be one that are pretty common. And so the point is that if you have a patient who's got some sort of compromised renal function and you're thinking about antibiotics, always think to yourself whether or not it's going to be something you're going to renally adjust. And you can always look that information up, but just keep that in the back of your mind whenever you're thinking about antibiotic prescribing. All right, I've posted some resources here. IDSA is Infectious Diseases Society of America, and they have all the major guidelines for current topics. You aren't going to find every single thing on there, but you'll find a lot of it. So if you really want to dig into the guidelines and look at some of the literature they're citing, that's a good reference to check out. It's a pretty user-friendly website. It's free. You don't need a special membership to have access to it. So browse that at your convenience if you want to. And just know that the guidelines can be quite long, but you can always find, there's usually some nice tables in them that kind of outline things pretty well. So you can use your control search functions and try and figure out what you want, find what you want quickly. Sanford Guide is probably something you may or may not be familiar with. Sanford Guide is a paper reference that a lot of people have, and it historically were these little small pocket-sized books that people would carry around with them. Now it's available online a lot of places. For example, Alina, which is the system I work in, has access to Sanford online. And the really nice thing about Sanford, and probably its most functional tool, is a table that shows you all antibiotics and their spectrums of activity. So it'll give you a plus or a negative or something in between if it's questionable coverage. So if you're ever wondering, you get a culture back and it's growing something odd, and you look on Sanford and you're trying to figure out what to prescribe somebody, that's a good tool to start with, and you can look at the coverage based on what Sanford has compiled. It's a pretty reliable reference. It's something that I use a lot when I'm kind of stuck. So if I have a patient with a lot of allergies and maybe some resistance showing up on their culture, that may be a source I go to say, okay, what are our options here? What actually covers this medication, or what covers the specific bacteria we're looking at? And is that medication an option based on allergies and sensitivities? And we'll talk about all this stuff in a little more detail here. CDC, Minnesota Department of Health, has lots of references beyond. They have the vaccine schedules, of course, which I talked about. They have a lot of references beyond that. They have references on a lot of different common pathogens and treatment and education for patients. So that's a good reference. One thing we use a lot for education are their STD protocols. So when we're treating patients and calling patients to give their positive results to, we'll give them education based on Minnesota Department of Health recommendations and CDC recommendations. Some other paper references out there that people like. Personally, I don't really use these because I find that information can be gathered from other places, but a lot of people like different stuff. So really, whatever works for you, as long as it's a reputable source. The Emergency Medicine Residents Association, EMRA, puts out a little pocket book that's a pretty nice, succinct summary, and they put that out every year. That's got some good infectious disease tips in it. And then there's the Johns Hopkins Antibiotic Side, which is another pocket book, which is a pretty thick pocket book. You probably won't actually want to carry it around with you, but is available for people, and it's people to use, and it's got some information that I don't think you can get necessarily in other places, and it's a pretty good comprehensive review. But again, I think that for most people's practices, I'm not sure how relevant that's going to be, but it is available if that's something you like. And then, of course, you have clinical specialists to work with. If you have a complicated infectious disease patient, don't hesitate to refer them to somebody who specializes in ID. That's probably the best way to do it, as opposed to trying to manage them with a lot of different antibiotics and risk failures and resistance and side effects and all those nasty things we don't want to do. I put pharmacists on there too because we do have pharmacists that specialize in infectious disease, and they can be a reference to a lot of hospitals use them, not in the same way they would use an ID physician, but on similar task forces and stewardship teams and other clinical opportunities like that. Antibiotics effects on this slide. So a couple different terms we're going to be talking about throughout this lecture. The first is mean inhibitory concentration, or MIC. I'm going to show you an example of how the lab is going to be reporting antibiotic sensitivities to different bacteria. And if you've worked in medicine, you've probably seen these before, but we'll talk about them in a little bit more detail to explain what exactly is going on here. So mean inhibitory concentration is the theoretical concentration, or the laboratory-based concentration of how many particles of drug you have to have per volume of blood in order to get effective killing rate of the actual bacterial pathogen. And so it just the concentration at the site of action. So if you need to get it into the urine, you need that concentration. If you need, I said blood previously, probably misspoke there, but if you had a bacteremia, you'd need to do that concentration within the blood. So it depends on the site of action, which can also affect the type of antibiotic choice we're making, because some antibiotics don't necessarily get to the site of action we need. So that's always something to think about as well. And then cutoffs are something lab decides too. So they may get an MIC back that's really high, and because it's so high, because you need such a high concentration of antibiotic to kill a certain bacteria, they're going to cut that off and say, sorry, this isn't sensitive. This is what we would consider to be resistant, and that's where they make those decisions. Bactericidal versus bacteriostatic. Bactericidal, it's how it sounds. Bactericidal kills bacteria. Bacteriostatic just prevents the growth of it. So slowly the bacteria is going to die off, but they aren't going to be replicating. So they're useful. They're just a little bit slower than our bactericidal. So usually, if you can get by with a bactericidal agent, it's generally more preferred over bacteriostatic, just because it's going to be a bit faster of a killing rate than your bacteriostatic agents. And then bactericidal, there's a couple different subtypes. There's concentration dependent, meaning really you just have to get that high enough MIC in order to kill the bacteria effectively. And then there's time dependent, which really you just need to be above a certain MIC for a certain amount of time. There's advantages and disadvantages to both. Concentration dependent, problem with it is sometimes the concentrations are so high that you have to get to really get good bactericidal activity that you end up causing side effects on the patient. And time dependent can be problematic because it may not be as fast of a killing rate, but and you may have to monitor the patient more frequently using blood draws and stuff like that in order to be sure that your concentrations are staying where you want them to. And there's some hybridization of this concept too, ratio of area under the curve to MIC, and I'm not going to get into too much detail on that, but I just wanted to mention it here. So this is a typical report you get from your laboratory, and I've got a urine culture here as an example. You can see that this is E. coli, and the patient is growing greater than 100,000, which is what lab reports as pretty much the highest amount. That means there's a lot of bacteria shown in the urine. And they'll give you a report based on different group of antibiotics. So sometimes you look at this and you're like, well, why are they doing sensitivities on certain antibiotics and not other ones? Well, for the most part, these tests are pre-made, so they buy the test from a company that makes them, because this company puts this snapshot of antibiotics against this bacteria. Now, if you really wanted to test it against something else, the lab does have the capability to do that. They can go in and do specific testing on specific agents, but this is the standard thing you're going to get. And this can vary a lot institution to institution, so you may not see this. This is how our ones at Alina look, but you may not see this at all places you get, or you may see slightly different variations of this. For example, sometimes it's tailored to formulary too. Our formulary carbapenem is imipenem, and if your formulary carbapenem was meropenem, you might see meropenem on there as well, or meropenem on there instead. So it just depends, again, on your formulary, the hospital, what exactly they want to use it for, and what company they're buying the test from. But a couple other things to point out, you can see here the numbers, and I'll point this out with my cursor here in this column. These are your MICs, and then the resistance, intermediate, and susceptible, that's what they're determining the cutoff at. So look at ampicillin. Ampicillin has an MIC greater than 32, and lab's saying, well, anything over 32 is resistant. So we aren't going to give you an exact number on that, but we're going to call it resistant. Whereas the ampicillin sulbactam or unicin is intermediate, and that's got enough MIC to probably give you some effective killing of the bacteria, but it's still lacking the low MIC we want to get an effective killing rate. And then you have something like a Cephazidime or Ancef, and that's showing that the MIC is likely less than 4. And again, lab's saying anything less than 4 is fine. One question I've gotten from providers a couple times is, like, let's compare Cephazidime to ceftriaxone. Okay, ceftriaxone is Rocephin, Cephazidime is Ancef. They're both really commonly used cephalosporins. Is it better to use one or the other? And the question being is that, well, one has an MIC less than 1, one has an MIC less than 4. The answer is no. Based on the cutoff, that does not matter. We know that it's sensitive. And lab's not going to report an Ancef MIC less than 4. They're just going to say less than 4 is good enough. We don't really need to say any more than that. And with ceftriaxone, they're saying less than 1. So just because you see something, an MIC, don't get too hung up on the numbers. Get more focused on the cutoff. There's one exception to that, and that's vancomycin. Sometimes, even though it says it's susceptible, sometimes with an MIC of 2, we consider that to be a problem. But I'll talk about that in a sec with vanco on that slide. Other things to point out on here, I think I've covered pretty much everything. Just really focus on the resistant and susceptible points here and tailor your therapy based on that. To talk about antibiotic resistance and stewardship a bit before we get into the drugs itself is important. Resistance is a huge deal within the antibiotic community and within the medical community in general. It's a constant threat that we're going to lose out antibiotics. And in fact, we're seeing some really super resistant, specifically gram-negative infections that sometimes there aren't really good treatment options for. We don't have anything that really covers it. We have our biggest guns may have questionable sensitivity against it, and sometimes you're just left with nothing. And that's the big fear, is that we're going to end up developing superbugs that don't have any drug that can really touch them anymore. And fortunately, that's not a super common occurrence currently, so you do see it occasionally, and there are reports of it. And there are definitely reports of growing resistance patterns, but we do still have some antibiotics that work. They're just very broad spectrum. Now the question becomes of how long is that going to last, and when are we going to finally lose out on those antibiotics we have that are the current, last line therapies? And that's the real scare there. So how do we prevent this as providers and as healthcare professionals? Know your local resistance patterns really well. You should know that certain things, for example, we can use the example of E. coli on the other slide and UTIs. E. coli is notoriously resistant to Bactrim in the Twin Cities area. It's got about 70% coverage rate. So that means, over almost a third of patients you would prescribe Bactrim to would not get effective coverage if you're prescribing it empirically. So we've moved away from Bactrim completely and looked at other options. Cipro is another option for UTI. Cipro has also been showing growing resistance rates. So we try and use macrobid or nitrofurantoin, or cephalosporin now is getting a lot more common because they cover the bugs a lot better. So being smart about how you prescribe antibiotics is important, and knowing your resistance patterns is a good thing to have a good handle on, because if you don't know them, you possibly are going to be getting people coming back with other infections and switching their antibiotics, and now you've exposed them to 2 different drugs and possibly created a resistance scenario there, and we don't want that, of course. Hospitals and health systems publish antibiograms. I've got an example of one of these coming up, and I'll talk about it there. But these are your friend. You should use them. If you don't have to use an antibiotic, don't use it. I think that's another big problem we have in our society in general, and this is maybe more of an ethical dilemma, or I don't know how you want to put it, but within primary care, there's often indications where it's difficult to tell whether it's a viral infection or a bacterial infection. But in cases like, for example, a sinusitis, which is almost always viral, you can think about it as considering maybe not prescribing an antibiotic right away, or really being careful and reserving those. Don't think about antibiotics as something you can just give out without consequences. Think about them as a precious resource that we don't want to squander on something that doesn't need it. And the same thing goes for broad spectrum agents. Don't prescribe something broad spectrum just because you think it'll get better coverage. Prescribe something that's appropriate. There's definitely appropriate situations where broad spectrum agents are warranted, but if they aren't, and if you can get by with something narrow spectrum, you definitely want to try that. Other points to consider when you're working up a patient, look at their history. So think about exposure. Have they been in a health system recently? That's important. If they just got out of the hospital, now they're coming back with a pneumonia, well, you could consider that maybe community-acquired pneumonia, but you might want to also cover hospital-acquired pathogens as well, because you can't really rule that out. Previous cultures are important too. If you have access to other micro lab data, you can look at what they've had in the past. This is a really easy way to figure out empiric therapy. So if you've had a patient who's coming back with a urinary tract infection, and this person has had E. coli 3 times in the last year, and you have 3 different cultures to look at, you can look at how the sensitivities have changed or if they've stayed the same, and really prescribe appropriately based on what they've had in the what their history has been. Because usually resistant patterns, they can change time to time, but for the most part, you're going to think about them being fairly the same in patients. If patients have a culture in the past that was sensitive to everything, and today they're back with a UTI again a couple months later, you can probably consider prescribing the same thing because you know that their culture was likely sensitive. And then, of course, length of treatment and allergies. Length of treatment is important. Know your durations. Don't just make up durations on your own. Look at the recommended durations based on the manufacturer's data, based on IDSA's recommendations. And also allergies. Allergies are something sometimes we can't get around. I'm going to talk about allergies a little bit more, specifically with penicillin class and beta-lactams in general. But the bottom line is, ultimately, we want to prevent losing certain classes of drugs, because if we don't, we may lose some options for treating certain resistant pathogens. This is an antibiogram. So I mentioned this on the other slide, and you can see Abbott Northwestern Hospital. This is from 2011, so it's a little old, but you get the point here. What it is it's showing you your this is gram negatives, there's gram positives, and it's showing you a comparison of different antibiotics and what percentage susceptible they were. So let's look at Bactrim. So here Bactrim and E. coli was 80%, and Bactrim's actually in the last few years has dropped substantially. It's closer to 70% now. But we see, let's look at Enterobacter, 95, 100% coverage. So there's definitely some good uses for it here. You just see maybe some dropping in resistance patterns. And you see E. coli with ciprofloxacin, 77%. So pretty low coverage. And those are, you think about Bactrim and Cipro being some of the first line options that we've used historically for UTIs, really have fallen out of favor recently because of their high resistance rates. So if you have access to this, every hospital has these. Usually you can find them online on the hospital's website. If you can't, you can always consider contacting somebody within an infectious disease and see if they can get you a copy, because they do print these in paper forms every year, and they should be floating around the hospital on different stations. All right, beta-lactams are a pretty widely used class of antibiotics, and there's a lot of different subsets. We're going to spend a bit of time on them today. This is just some structures to show you that all beta-lactams are pretty comparable in structure, but very slightly. So really what the beta-lactam ring is outlined in blue there. And so every one of these penicillin, cephalosporins, monobactams, and carbapenems are all beta-lactams, and they just vary in their subgroups slightly. And then you have the R groups that can be a lot of different things. So for example, cephalosporin may have a more complicated R group. Some other ones may have more simple R groups. But this is the basic structure behind how they work, and they're all related to a certain degree. So there's a lot of drugs that are classified as beta-lactams. Beta-lactams are all bactericidal. They have pretty fast killing rates, which is an advantage to using them. And they all work by inhibiting formation of the bacterial cell wall. They're time-dependent killers, so really you need time over MIC. So you want just to get that MIC up to a certain amount. So we don't have to load people with massive doses of beta-lactams. We just have to keep a relatively decent dose consistent throughout the course of treatment. The agents within the beta-lactam class vary substantially with respect to spectrum of activity. Some of them are very narrow spectrum, and others are some of the most broad spectrum agents we actually have on the market. Bacteria, whether they have intrinsic abilities to do this or have developed it over time, they have the capability to produce beta-lactamase enzymes. And this does what you think it does. It's an enzyme that's specifically designed by the bacteria to break down the beta-lactam ring within the drug. So what we can do is develop drugs that counteract this beta-lactamase. So some drugs you'll see that are coupled with a beta-lactam are beta-lactamase inhibitors. And a great example of this would be Augmentin and Unison. So amoxicillin by itself is just a beta-lactam. Augmentin is amoxicillin plus clavulanate, which is a beta-lactamase inhibitor. So we see that strategy being used to extend the spectrum of activity of the beta-lactam class. Penicillin is one of the oldest antibiotics we have. It's derived from bread molds, natural defense mechanism, and it was isolated that way. And that's kind of what started the beta-lactam class, and everything's really been built off of that. There's a lot of benefits with beta-lactams. There's not really a lot of drug interactions to think about with them. They're almost universally tolerated in pregnant patients and children too, so that's another really great option with beta-lactams. Problem, most are dosed at least 2 to 4 times daily, so not the most convenient drugs in the world, but at the same time, again, the side effects profile of them is pretty mild for the most part. So you get a well-tolerated drug with maybe the trade-off of a slightly higher frequency dosed medication. This slide shows the penicillin binding proteins, which are the blue rectangles up here, PBP. And what these do are the penicillin binding protein is a product that is a compound that's going to is a protein that's going to be I'm not speaking correctly, a protein that's going to be building the cell wall for the bacterial. So we can see this yellow thing is our bacterial cell wall. Penicillin binding protein is building that. And why it's called penicillin binding protein is because that's where penicillin binds to. So B here, this red B is the beta-lactam. In this case, let's say penicillin. It binds to a site on here, meaning that that protein cannot continue building the cell wall like it should. Alternatively, you have other drugs, and this is just an example. This G is supposed to be vancomycin. Why they didn't use a V, why they used a G, I have no idea. I didn't make this drawing. But it's a V that, the vancomycin is the G. And so this would instead hook onto the actual chain of amino acids so that the penicillin binding protein can no longer hook onto it. So it's working really the same way, it's just slightly different. The same outcome, it's just slightly different mechanism. You see that vanco has a similar mechanism of action to penicillins and other beta-lactam class. So that's kind of an interesting thing to think about. And they can be synergistic in the way they work because they're targeting the same mechanism but just slightly different. All right. Side effects in general can be lumped into pretty much one group. There's not a lot of differences, and I'll talk about a couple outliers here and there when we talk about the drug specifically. But minimal side effects. They're very well tolerated agents. Biggest side effects specifically with a drug that's coupled with a beta-lactamase inhibitor is diarrhea and GI-related effects. Reason being is that all antibiotics have some capability of wiping out some of the natural GI flora, so they can cause an imbalance there, put you at risk for having diarrhea or nausea or some other GI-related symptoms. And further on can increase the risk of pseudomembranous colitis, which is what we would refer to as Clostridium difficile infection. But the problem with beta-lactamase inhibitors is that when you add that to a beta-lactam, you get better anaerobic coverage, which is good if you're targeting anaerobic-related infections. It's bad if you're just going to end up wiping out some of this GI flora. So that's can be a problem with that. And so that's why we worry a little bit more about that when it's something with a beta-lactamase inhibitor. In high doses or with accumulation, the risk becomes central nervous system toxicity with these medications. And this would be a really unusual situation. I'll talk about imipenem, which probably has the highest risk out of anyone. But most of these, probably not something you need to worry about. But coma, seizures, reflex type reactions, myoclonic reactions could be something you might see with a really high dose. And that's why we try and renally adjust these so we aren't getting too much accumulation. Most are really good in pregnancy and lactation. I'll say that again. There's very few contraindications or restrictions on using them. Allergic reactions are probably the biggest thorn in the side of the beta-lactam class, and that's because a lot of people report allergies to them. I'm going to talk about that specifically and how we interpret that and how we might get around that in situations. So hold on for a second with that. All right, penicillins. Basic penicillin is still useful today. There's penicillin G, which is IV or IM. The IM is this benzathine stuff, and you can see it here. It looks kind of like this milky fluid. You give that for like a strep throat or syphilis. We give that for. Penicillin VK is oral. It's a tablet or a suspension. Penicillin doesn't have a huge spectrum of activity. It's pretty narrow, and a lot of things are resistant to it. But it does work pretty well for streptococcus and meningococcus, also for syphilis. So those are two things where we really still see it used, and it has pretty good sensitivity to that. Most gram-negative bacteria are intrinsically resistant to penicillin, so we really can't use it for a gram-negative infection. But for those really basic gram-positives, it can work pretty well still. So there's some anti-staphylococcal penicillins. So this is a group of drugs that were developed off of penicillin to be more targeted to staph infections, and also still cover strep infections. So here we have oral tablet, dicloxacillin, cloxacillin, and IV nafcillin and oxacillin, 4 different drugs here. These drugs are not used very often. They're just about 4 to 6 times a day, and despite the fact that they've been around for a while, they're actually kind of expensive. Consider these to be extremely narrow spectrum in the sense that they're only used for MSSA infections. These are never used empirically. They're never used for anything unless you can narrow it down to a patient who has a staph infection and it's a methicillin susceptible. And the counterpart being to the MRSA or MRSA infections if they're methicillin resistant. Methicillin was an old anti-staphylococcal penicillin, and it's still that nomenclature is just used. Essentially, if you see resistance to staph, to oxacillin, or one of these other 4 drugs on your susceptibility report, you can consider that MRSA. A lot of times they're going to report it as oxacillin resistant. That's how we know it's MRSA resistant. Or that's how we know it's MRSA and not MSSA, excuse me. Again, not used empirically. One thing to think about too, nafcillin is something that is used occasionally. Again, if you're in the hospital and you narrow down an MSSA infection, you may use nafcillin. Nafcillin is a really strong CYP enzyme 3A4 inducer. And so your CYP enzymes are, especially 3A4, responsible for metabolism of probably close to 50% of hepatically metabolized drugs on the market. And so that's a big deal. If it's going to induce that enzyme, you can end up with some pretty substantial drug interactions. So that can be a problem. And that's why another reason why these drugs aren't used all that often. All right, so some other penicillins. These are called extended spectrum. And we'll talk about the base drugs first. So let's talk about amoxicillin. Amoxicillin is an anti-staph penicillin. It'll cover MSSA in a lot of situations. It'll cover strep. And it's got pretty good coverage against some gram-negative organisms that are non-resistant. Very basic coverage. I wouldn't ever use it empirically to cover gram-negatives, but it would cover a lot of them, on a basic level. And then once you add the beta-lactamase inhibitor, which I've got in blue there, the amoxicillin plus clavulanate or ampicillin plus sulbactam, you extend the gram-negative coverage substantially, plus you get anaerobic coverage. So that's going to just add to your arsenal here, where you can treat empirically. Sometimes you'll see augmentin used empirically over just plain amoxicillin, just because it's a more effective drug for a wider variety of pathogens. And in case you're curious, augmentin and unison, or amoxicillin and ampicillin, can be converted interchangeably with each other. And even though they're different drugs, we consider them to be the same as far as their spectrum of activity. So amoxicillin is the oral version of ampicillin. Augmentin is the oral version of unison. The other drug we have in this class is piperacillin plus tazobactam, which is Zosyn. And Zosyn is a really broad spectrum agent. So in addition to everything that augmentin and ampicillin and unison can do, you have the added effect of pseudomonal coverage and other gram-negative coverage. So this is still going to cover your basic gram-positive. It's going to cover a lot of anaerobes, and it's going to cover quite a few gram-negative species, including the more resistant, hard-to-treat ones, which we kind of say Pseudomonas as the poster child for difficult, hard-to-treat gram-negative infections. And this is one drug that covers Pseudomonas. So when you're looking at something to cover somebody who's maybe had exposure to healthcare and you're concerned about Pseudomonas, Zosyn's a drug that works pretty well. Zosyn has bad CNS penetration. In fact, interestingly enough, the piperacillin component gets into the CNS really well. However, the tazobactam, the beta-lactamase inhibitor, does not. So you may get some coverage with that piperacillin, but what really makes piperacillin so powerful is its coupling to that tazobactam with the beta-lactamase inhibitor. That's what gives it such a great spectrum of activity, the combined use of those two agents. So if you take away the tazobactam, you do lose some efficacy there. I did put ticarcillin and clavulanate, or timentin, there. I don't know if people use timentin. Timentin's kind of in between. It's not quite as broad spectrum as Zosyn, and it's it's more broad spectrum than augmentin would be, though, or unison would be. So I don't think many health systems use this. I think if you're going to go broader than unison and you want to stick in this area, you would go with Zosyn. So there you have it. To talk about Zosyn a little bit more, you may see this in different hospitals. I think a lot of places are doing this now, and it's called an extended infusion strategy. So Zosyn, as an IV drug, is dosed Q6 hours. Beta-lactams are time-dependent killers. So the strategy that's been researched is, what if we just infuse the drug over 4 hours instead of 1/2 to 1 hour? That way, instead of getting these bursts of high concentrations of drug after the infusion, if you infuse it steadily over 4 hours, you get a really gradual peak, and you can keep your steady state levels very consistent throughout the entire infusion and post-infusion period. So we've actually started doing this and the research shows pretty good evidence that you decrease resistance rates by doing this, and you improve overall outcomes by doing this. So we've actually switched to this at Abbott. We switched a few years ago. A lot of places, as far as what I understand, do an extended infusion strategy around the country as well. It's really the best option we have based on the literature right now, so should be seeing this done. In fact, if a provider orders Zosyn traditionally dosed at Abbott, we have the power as pharmacists to automatically change that to the extended infusion. So that's a hospital protocol and policy. So interesting. But in case you see that, that's what's going on there. All right, moving on to cephalosporins. There's a lot of cephalosporins out there. They all kind of sound the same as far as their name. They're all Cephs or CEFs or CEPHs. There's a bunch of different generations, first through fourth, maybe fifth generation, depending on how you want to look at it. They have a similar side effect profile to other beta-lactams, so pretty well tolerated. Generally speaking, the lower the generation of cephalosporin, so if you start with the first generation cephalosporin, you're looking at something that's really going to cover pretty basic gram-positives, like staphs and non-resistant forms of staphs and streps. Then the higher you get in generation, you're adding on a lot of gram-negative coverage and maybe some extended gram-positive coverage as well with a couple agents. So think about it that way. The higher the generation, you're adding on more gram-negative coverage, essentially, is a good way to think about it. All right, generation 1, first generation. Kind of like how amoxicillin and ampicillin are interchangeable PO and IV, cephalexin and cefazolin are pretty interchangeable PO or IV. So Ancef is the IV version, Keflex, sorry I spelled Keflex wrong, Keflex, Keflex, not Kelfex. These are our two workhorses. These drugs have excellent staph coverage, specifically with MSSA. They don't cover MRSA, but for our non-resistant staphs, they're great. They have great strep coverage. They cover some gram-negatives as well. These have really good E. coli coverage too. And when I was talking about how with urinary tract infections, we're moving away from Bactrim and Cipro and moving towards drugs like macrobid and cephalosporins, this is one of the cephalosporins we like to use a lot. It's got about 90% coverage of E. coli, so it's a pretty good empiric choice. It's, again, really well tolerated too. So you can't really go wrong with it, of course, unless somebody's allergic to it. The other thing we use these drugs for is skin and soft tissue infections. They're really our workhorse for basic cellulitis, surgical prophylaxis, and other skin type conditions that we might want to treat. So widely used, very, very useful drugs, and pretty good drugs too. Just very well tolerated and good spectrums of activity. All right, second generation, I'm not going to spend a ton of time on these. There's a couple ones I'll point out. Let's see. So there's the two ones in the first bullet point here, cefotetin and cefoxitin. What these add to, what these have, I guess, as a uniqueness within the cephalosporin class is the most expanded activity against anaerobes. Why this is important is because if you're thinking about covering GI-related pathogens, so if you have somebody with appendicitis, or something, or diverticulitis, something intra-abdominal, you want to cover both your standard gram-negative organisms, specifically E. coli, which we know cephalosporins cover well because our first generation cephalosporin covers E. coli. So we can assume that pretty much every other generation of cephalosporin will cover E. coli. So we have that covered. What we want to add on is anaerobic activity. And cefotetin and cefoxitin both cover Bacteroides pretty well. So useful for abdominal surgery as monotherapy. So a lot of times with drugs when we're treating intra-abdominal infections, we have to use two different drugs, one to cover gram-negatives, one to cover our anaerobes. And this is one case where if you're giving IV therapy, because these aren't available orally, you can give one drug with cefoxitin or cefotetin and get by with that. The other drug I have here, IV, which is also available PO, is ceftriaxone, and I'll talk about them together. Ceftriaxone, Ceftin, and Zinacef are the counterparts of each other. Zinacef being the IV, Ceftin being PO, and these cover everything as first generation would. Plus, they're going to expand on their the gram-negative coverage a little bit more. So we think of ceftriaxone as maybe a step up when we're treating gram-negative infections. So an example would be if we have somebody who's come in maybe and failed a couple different treatments for a urinary tract infection, they might try ceftriaxone because it's a little bit more potent of a cephalosporin and it should cover a few more strains of E. coli, more resistant strains than cephalexin would. The other two, Cefalocor and Cefprozil, are also in the same category. You don't see them used a lot, and I'm not too worried about those from a test perspective. All right, third generation. So there's two different types of third generations that are IV. We have not active against Pseudomonas. This would be ceftriaxone or Rocephin or cefotaxime. And they are active against Pseudomonas, which is Ceftazidime. So let's talk about the differences with these. Ceftriaxone or Rocephin is a huge workhorse antibiotic we love to use. Couple great things about ceftriaxone to point out. It's not renally cleared at all. So when you have an older patient or a patient with compromised renal function and you need to treat them with a cephalosporin to cover their UTI, this is a great drug to start out with. It's also once daily dosing. We do dose it twice a day for indications like meningitis, but most of the time it's just a once a day dose medication. It's also a cornerstone of inpatient therapy for community-acquired pneumonia as part of a combination therapy we do. And we'll talk about that a little later. But Rosefen's just, again, it's got a great amount of activity against basic gram-positive. So again, we have our basic first-generation coverage. We have our MSSA coverage, our strep coverage, and we're just adding more gram-negative coverage. Ceftriaxone has pretty good gram-negative coverage. Also has some anaerobic coverage, just not really enough to be used as monotherapy in the case of an intra-abdominal infection. All right, cefotaxime, not really worried about that. In fact, cefotaxime's been on shortage for a while. We can't get it. I'm not sure if it's being made anymore, or if it's just a supply issue or what, but we haven't been able to get it for a while. It's kind of similar to ceftriaxone. It's renally cleared with a shorter half-life. Cefotaxime, I believe, is preferred in pediatric patients. One of the problems with Rosefen is in young kids it can cause biliary sludge, and which can lead to kernicterus as an unpleasant side effect and undesirable side effect. So usually Rosefen's avoided in pediatric patients, and we use cefotaxime. Not terribly important to you guys probably, but just an FYI. Orally, there's no oral option for ceftazidime. I kind of glossed over this one. Ceftazidime has Pseudomonas coverage, which is good. The only problem is it has pretty bad gram-positive coverage. So it's one of the few cephalosporins that when we increase in generation, while it gets better gram-negative coverage, it actually loses some of its gram-positive ability, specifically with pretty variable Streptococcus pneumoniae coverage. And that can limit its role in treatments of things like respiratory infections. Orally, there's no oral generation of cephalosporin that covers Pseudomonas whatsoever. There are some third-generation oral products that you could consider them kind of the same as ceftriaxone as far as coverage goes. So Cefixime and Cefdinir, they have really good gram-negative coverage. Staph and strep coverage probably is there, but weak. Cefdinir is one that's used a lot in kids for urinary tract infections. And Cefixime, again, is just an upgraded cephalosporin that you could give orally if you need to. Moving on in generation, fourth, fifth, new cephalosporins. The one I'm most concerned here about is Cefepime. Cefepime is the most broad-spectrum cephalosporin used in current practice widely, I should say, because there's some new ones that are out now. But it has really good pseudomonal coverage, better gram-positive coverage compared to ceftazidime. So you get good pseudomonal coverage without losing your strep pneumo coverage like you would with ceftazidime. It's got good CNS penetration, so you could use it for like a meningitis or central nervous system infection. It's a great broad-spectrum negative coverage when anaerobes are not of concern. So Cefepime really doesn't cover Bacteroides or other potentially pathogenic anaerobes like a drug like Zosyn would cover. However, it pretty much is the same coverage as Zosyn otherwise. So you can kind of keep this in the back of your mind as a good broad-spectrum agent if an intra-abdominal source isn't necessary or you don't need any additional anaerobic coverage. The other ones on this slide I'll talk about just for the sake of mentioning them. Ceftaroline may or may not be getting more use out there. It's the newer cephalosporin. It's the only cephalosporin with methicillin-resistant staph aureus or MRSA coverage. It has decent gram-negative coverage, but no pseudomonal coverage, and the role in therapy is variable. It's got indications for community-acquired pneumonia and skin and soft tissue infections. It's something that could be used, but isn't getting used substantially in our health system. I'm not sure about other ones. It's new and therefore a little bit more expensive than some of our current options. And then fifth, put these all kind of as fifth generation. So Ceftobiprole is this drug that's been on the market forever, or been on the market in Europe for a while. It just won't come over to the US. And I think there's been some legal issues with the drug companies in deciding who actually owns the product, keeping it off of the market. It's supposedly a drug that essentially is like Cefepime, where it covers virtually everything, but it also has MRSA coverage. So it'd be a really interesting drug where it hit the market because you could really do broad spectrum therapy with it as monotherapy. Because right now, if somebody comes in and we want to start broad spectrum approach, we'll do like a Cefepime Plus, we'll add a drug to cover MRSA, like vancomycin or something else, usually vancomycin. Finally, there's 2 new drugs on the market that I'm really not concerned at all about. One's Ceftolozane, tazobactam, and the other is Ceftazidime, which we already talked about, avibactam. These are just like 3rd generation cephalosporins that they added a beta-lactamase inhibitor to. It extends their gram-negative coverage a bit. I can't remember for sure if they've shown that they have good pseudomonal coverage or not. I believe they do. It also extends their anaerobic coverage. These both have indications for intra-abdominal infections. Interestingly enough, even though they're combined with a beta-lactamase inhibitor, it's still recommended to add on additional coverage of anaerobic bacteria. So I don't really know how effective these are going to be or how widely used they're going to be, but they are available right now, and I don't think we're going to be seeing much use, but you may end up seeing them, in the future if the cost comes down and if we see that there's maybe a better role in therapy for them than currently there is. Carbapenems are the next class. Carbapenems are massively broad-spectrum, IV-only, gram-negative agents. Cover anaerobes. They cover some basic gram-positives. Think about these being very similar to Zosyn, but they're slightly more resilient to bacterial defense mechanisms and cover things slightly better. So they're even going to be a bigger option than Zosyn. Imipenem, meropenem, and doripenem are 3 different ones. Basically all interchangeable. Depending on the health system you go to, they'll likely have one of these on formulary, not all of them. Primaxin is our formulary agent. I know a lot of places use meropenem. Primaxin's problem is it's got the highest seizure risk clinically of any beta-lactam, but in the clinical trials, it was used at a little bit higher dosing than what's used in practice, so it's likely thought that's not a huge issue. Imipenem is not combined with a beta-lactamase inhibitor. That cilastatin is actually this inhibitor of a product or an enzyme called dihydropeptidase, which is a natural enzyme that the kidneys make that can break down imipenem by itself. Meropenem and it also doesn't really penetrate the central nervous system. So for really resistant infection, you can't use it in the CNS. Meropenem has a lower seizure risk than imipenem and better CNS penetration. So some people will argue meropenem is maybe the superior one. Doripenem is more like meropenem as well. I feel like people don't talk about doripenem all that much. I'm not sure why. But essentially, they're interchangeable. And again, it's going to be a hospital formulary decision. Ertapenem is the other penem, and this one is virtually the same as all the other ones, except it does not cover Pseudomonas. So it's important to know that ertapenem is a really good broad-spectrum gram-negative agent. You just wouldn't use it for really resistant infections like pseudomonal infections. All right, so I mentioned some things about allergies with beta-lactams. Let's talk about cross-reactivity and how concerned we have to be. So people report penicillin allergies really commonly. Up to 10% of patients will report a penicillin allergy. Now, studies have shown that most of these patients, if you actually tested them, would not actually be allergically react to it. So the question is, first of all, your pool of people out there who are saying they're allergic to them, how many are actually allergic? We don't know. So it can be questionable whether you take a penicillin allergy seriously or not. However, when in doubt, you don't want to give the patient an anaphylactic reaction or really bad hives or something like that. So we usually take them seriously. And we don't have the luxury to do a special like sensitivity test on somebody in most situations. So we just take their word for it. Okay, we'll move on. Now the question is, if you have a childhood reaction, are you still allergic to it? It's difficult to say. Probably not, but again, we don't have the luxury to test people. And the other thing to always check into is whether it's actually an immune-mediated reaction or something else. So usually what I think about is anaphylaxis or hives being a pretty strongly immune-mediated reaction. If people had a drug rash to a penicillin, is that going to deter us from giving them a medication that could possibly save their life in a certain situation? Absolutely not. We don't really care about the rash. It's not really going to be a substantial reaction that way. So it's really those really strong immune-mediated reactions. Now, the question is, if we want to be on the safe side and somebody's allergic to penicillin, what do we do? So if let's say we wanted to give somebody amoxicillin, but we can't because they're allergic to penicillin. What about cephalosporin? Can you do that? Studies have shown that cross-reactivity is about 2 to 3% for truly allergic patients. Some studies have shown up to 10%, but that study that found that wasn't really all that well designed as opposed to the other ones. It's likely a lot lower than that. So if it's something that's like, let's use the rash, for example. Maybe you don't want to give somebody a rash again because it's like, well, it's just amoxicillin. I can get by with an alternative and not give them a rash. Let's try that. Do cephalosporin. That'd be a great option. The risk of cross-reactivity is so low, and the fact that they got a rash with their penicillin before may or may not have even been from penicillin. Cephalosporin is probably a pretty safe choice. Second option we could try is a carbapenem. Carbapenems have extremely low cross-reactivity, probably 1% or less. And so this is really where we go in our hospital. If we have somebody who we need to give broad-spectrum antibiotics to, let's say we want to start them on Cefepime and vancomycin for maybe suspected sepsis, but they have a penicillin allergy that's anaphylaxis. Well, we don't give them Cefepime, we'll give them Primaxin or imipenem instead because the cross-reactivity is so low that it's likely negligible, and we want to avoid even that slight risk with the cephalosporins. Now, one thing you can do that's an easy way to check is just see if the patient's had anything in the past. With electronic medical records, you can do a really quick search in their medication history and figure out within a minute or less if they've had a cephalosporin or if they've had a carbapenem or if they even had amoxicillin before. You can see a lot of times people will get antibiotics and people don't actually check their allergies. They'll just prescribe something. And so they ended up, and the patient, for whatever reason, doesn't really notice that most patients wouldn't realize that that's, possibly would react with their old penicillin allergy. So they aren't going to say anything either. And they take it, everything's fine, and it's documented in the chart now. Well, now we can safely say something like, well, that patient's probably okay. So use your resources to figure out what patients have been exposed to, and that can help you out there. And then there's the graded challenge option. I've never seen this done, but if you really wanted to give somebody a cephalosporin, and they have a penicillin allergy, you could do a graded challenge where you give 1/100th of the dose followed by 1/10 of a dose, and then the full dose of the drug. And then hopefully that those first 1/100th and 1/10 doses would be enough to show you if the patient's going to react or not. But again, I've never actually seen that done to anyone. Finally, there's one other drug we can do, and this would be the ultimate decision if somebody was severely allergic to basically every beta-lactam out there. That's why this drug was invented, essentially. It's aztreonam. It's a broad spectrum like a carbapenem, but it doesn't have anaerobic coverage. So kind of like, think about it maybe like a Cefepime as far as coverage goes. It's IV only. Really, again, only going to be used for a truly severely beta-lactam allergic patient. And that's going to be somebody who's actually proven that they're have a hypersensitivity to carbapenems as well as other beta-lactams like cephalosporins and penicillins. So yeah, that's that. You probably will never see this prescribed. Okay. Are you getting a drink of water? So this is something I'm going to post after each major kind of group of drugs we talk about. And this is just to review the spectrum. So this is a good way to differentiate drugs and put them into different categories so that we can break things down at the very end of the lecture. So for MRSA, we've only talked about one agent that has MRSA coverage, Ceftaroline. We've talked about several anti-pseudomonal agents that are all listed there. And anaerobic coverage. We talked about some anaerobic coverage as well. I put some cephalosporins up there. Remember, cefoxitin has anaerobic coverage, and some other cephalosporins have a little bit here or there, but mostly we're just thinking about cefoxitin. Atypical pathogens, we haven't talked about anything atypical yet. Atypical pathogens would be Legionella, Mycoplasma, and Chlamydia pneumoniae, and we haven't had any drugs that cover those yet. So moving on to our next group of drugs. These are other gram-positive cell wall agents, so these aren't beta-lactams. They can work similar. Remember, vancomycin has a similar mechanism to beta-lactam. It just works slightly on a different site. All right, vancomycin or vanco is a really powerful gram-positive agent. It's actually, I think people think about vancomycin as a broad-spectrum antibiotic. It's really not. It really just covers gram-positives, but it's a good MRSA agent. So I like to think about vanco as purely MRSA coverage for most things. It does cover streptococcus pretty well. It does cover enterococcus very well. So it does cover other gram-positives, which we can use it for. But when we're using vanco, we're often just empirically treating or empirically covering MRSA. So IV, first line for serious MRSA infections, first line for pretty much any serious infection where you want to empirically cover MRSA. It's a bactericidal agent, technically, but it's kind of a slow killer. So where beta-lactams are a bit faster of a killer, vancomycin's kind of slow. So if we can get by with something else, probably would rather use it over vanco, but it's an effective agent, so I don't have any problem using it. It's just maybe not the best agent in the world. And then we do have an oral option of vanco. Really important here, oral and IV don't mix. So you can't like start somebody on IV vancomycin and send them home on oral. Oral is only used for Clostridium difficile infections within the GI tract, and IV is only used for systemic infections. IV therapy does not get into the GI tract, and oral therapy does not absorb to an appreciable level into the systemic circulation. You can see vanco is a really big molecule. I put the structure of it up here, so that may explain why it doesn't really penetrate across the GI barrier there. Let's see. So a couple other things about vanco. There's pharmacy to dose protocols out there. So a lot of times you can order a vancomycin pharmacy to dose, and your pharmacist will get that consult and they'll dose the vanco for your patient. So they'll go through the weight-based dosing, they'll do the monitoring. The reason we do this is because vanco is a time above MIC product, and we really want to make sure we're targeting specific levels. And so we do what's called kinetics, pharmacokinetics on vanco, where we're looking for figuring out half-lives. We're looking at blood concentrations. A lot of this we can predict based on the patient's weight and renal function. And then we draw a level, make sure if it's high, we decrease the dose. If it's low, we increase the dose. It's pretty straightforward. It can get complicated when you have specific peak targets and trough targets you're trying to hit. So for a patient with a central nervous system infection, you can end up doing some calculations to figure out things like patient half-life, patient volume of distribution, and we can use that to predict where our levels are going to be. Those are rare instances anymore. We don't do that a lot as a standard of care anymore. Vanco is thought to be ototoxic and renally toxic at high doses, so we do monitor it for those reasons as well. Higher concentrations targeted for more severe infections. Again, I kind of mentioned that central nervous system. And then Redman Syndrome. Redman Syndrome is kind of like an allergic reaction to vanco. What happens is a person kind of flushes and turns red. It's not really like a hypersensitivity type thing, but it does happen with vanco. And what we do is usually decrease the infusion rate. You'll stop the infusion of vanco, give somebody some Benadryl. You can start the infusion up at a slower rate. If the Redman returns, you can consider a different agent at that point. A couple other drugs. So what happens, vanco is our first line for MRSA. Daptomycin is kind of like second line. It's really expensive. It's like 10 times the cost of vanco, but it is pretty good for vancomycin-resistant agents. So vancomycin-resistant Enterococcus or staph aureus. Just to point out a side note, within Minnesota, I don't think we've had any documented cases of vancomycin-resistant staph aureus. So you're rarely going to see that. But we do see vancomycin-resistant Enterococcus quite frequently. And there may be cases where the staph or whatever we're trying to treat has a decent vanco MIC, but it might be kind of on the threshold between being susceptible and intermediate resistance. And so we end up treating with a different agent because we're worried about that vanco being just a little bit high on the MIC side. You can't use daptomycin for central nervous system or pulmonary infections. The pulmonary surfactant that your body secretes deactivates dapto. So if you're treating those types of infections, you have to look elsewhere. I'm not going to talk about these other two ones. They're rarely used, and it's really going to be ID specific, so I'm not going to mention them. I'll say one thing about Orbactive at the bottom, Ortavancin. This is an interesting drug for skin and soft tissue infections, and it's designed to be for outpatient patients who need MRSA treatment, who can't really tolerate any oral option. They don't have really many oral options for MRSA, or they're resistant to all of them, or allergic to them, or whatever it may be. But they want Oritavancin, and what it is just a one-time dose. It's got a 245-hour half-life. It costs $1,200. But the advantage is that sometimes if we need somebody to be on vancomycin as an outpatient, they have to come into an infusion center, or they have to have home infusion set up with them, so they're getting their antibiotics a couple times a day. With this drug, you give a one-time dose, and then you're theoretically cured of your cellulitis or whatever it is at that point. So it's kind of a cool thing that we may be seeing more of in the future. I'm not exactly sure of its role. I haven't seen any of it used yet so far, but we'll see. It could be kind of a cool option for some patients. Okay, so just adding a couple things here. We're going to add vancomycin and daptomycin to our MRSA. Remember, the other drugs I'm not really concerned about. Even though they do cover MRSA, don't worry about them too much. So vanco and dapto we're adding in. Moving on to our protein synthesis inhibitors. What these do is that, again, they're working intracellularly, and they're working on different parts of the messenger RNA. Some work on the 30S portion, 70S portion, and you can see the different drugs here, like tetracyclines and whatever. It doesn't have not really a good comprehensive list of drugs, but you kind of get the point on the mechanism here. It's disrupting DNA sequencing, therefore you can't synthesize proteins, and the cells can't replicate normally, and they'll eventually die. I put on this slide. Yep, atypical bacteria. They cover atypicals, which is a big area of bacteria we want to cover when treating community-acquired pneumonia. Also covers Streptococcus pneumoniae, which is the other big component of community-acquired pneumonia treatment. Tetracycline gets into the urine. It can be used for E. coli urinary tract infection. It can be used for central nervous system infections. The list goes on. It's a drug that's very versatile. So it's kind of one to remember that if you're like, you end up with a bunch of allergies on a patient, a bunch of resistance patterns, doxycycline can be possibly one that works. Tigecycline, I'm not going to mention it here. It's rarely ever used. There's a black box warning about a slight increased risk of mortality with use. Really end-of-line therapy, so I don't really want to spend too much time on it. Macrolides are another class of antibiotic that cover gram-negative and atypicals, and maybe some basic gram-positive coverage. Very tough on the GI tract for the most part. In fact, they cause some promotility. Erythromycin is rarely used as an antibiotic anymore, but it's used a lot as a promotility agent for people with like gastroparesis or something. Clarithromycin still has some role. It's used sometimes for H. pylori infections, which is a common cause of GI ulcers. And then we have azithromycin, or Zithromax. Azithromycin has kind of become notorious as the go-to for anything upper respiratory, including and unfortunately being over-prescribed for community-acquired pneumonia and inappropriately prescribed for community-acquired pneumonia as monotherapy. Problem with the azithromycin is it's become the strep strains we have in our communities across the country and most of the world become very resistant to azithromycin. So when you're treating community-acquired pneumonia, remember I said this before, you really want to cover strep pneumo and atypicals. Azithromycin does a great job with atypicals. It's terrible with strep pneumo. It's not recommended to use as monotherapy. And I'll say that multiple times, and we're going to go over a case on that, so hopefully that point sticks. This is referred to as a Z-Pak. I think that's another reason why people like prescribing it, because they could just write Z-Pak on a pad of paper and send it over historically. But again, we're really running out of good uses for azithromycin. So if you're going to prescribe somebody a Z-Pak, be really, I would second guess yourself and just make sure you're doing it for the appropriate reasons. Appropriate reasons maybe being something like, COPD exacerbation, possibly like a sinusitis, but there's not a lot of really a lot of good reasons to prescribe a Z-Pak anymore. There just aren't, except if you're adding it on to something for the added atypical coverage. Aminoglycosides. These are pretty much glossed over in a lot of areas because we don't use them a lot anymore. They're broad spectrum. They cover gram-negative bacteria very well. They used to be really popular until we got a lot of other drugs like Cefepime and Zosyn and carbapenems because they're all better tolerated and they cover the same things. They have renal and ototoxicity when they get high concentrations. So usually if you have somebody on an extended course of aminoglycoside, they will likely get renally toxic. I've seen it happen before. It's not good, and there's probably an alternative they should be on. Now, I will say that they're used a lot in OB, which is, of course, what you guys are going to be seeing them in. They have probably a lot of historical data in use in OB, not to say that they couldn't use alternatives for them, but for some reason, aminoglycosides have kind of stuck for things like choreo and endometritis, we still like to use aminoglycosides. Could you use other things? Again, probably yes. In fact, I've seen OB patients who are on kind of like the cocktail where they're getting ampicillin, gentamicin, and Clinda, and then some ID provider will finally get consulted. They come in, they wipe all those out and put them on Zosyn. Why? Because it covers all the same things. So just one thing to think about too is that the patient population of obstetrics, generally speaking, healthy young females who have decent renal function, if not really good renal function, and those are good candidates for aminoglycosides because they're going to clear the drug. They're going to be less likely. They're going to be more robust to the adverse effects of it, I should say. And that's going to allow for the advantage of being able to dose them once a day, get really high peaks of the aminoglycosides, give all the dose once, get this really high peak, and then watching it eliminate and then doing it again the next day. And that's a fairly effective strategy that works pretty well with the aminoglycoside. And in a lot of OB indications, it's a very short course. So you might just be doing a day or two of therapy until the patient's afebrile, and that's pretty common. So appropriate use, yes. Are there risks with them? Yeah, but in the cases of OB, I would say the overall treatment is a pretty short course, and it's in healthy patients that aren't really at high risk for these complications. So probably okay. Just really one of the only areas I see aminoglycosides used frequently in. All right, clindamycin is another kind of random medication that doesn't really have its own class. It's available PO and IV, which is nice. You don't have to renally adjust it, which is another nice option with Clinda. It's possibly bactericidal or static, depending on how high the dose you get. Bactericidal at higher doses. Good gram-positive coverage, good anaerobic coverage, but it's missing gram-negative coverage. It's just its biggest gap there. Clinda does cover MRSA a bit. It's variable with its staph coverage in general. Either MRSA or MSSA could cover it, maybe not. It's like 70% susceptible staph strains. We use it in anaerobic infections a lot, upper body. By upper body, I mean like the ENT type stuff. So if you have somebody with an ENT infection, you're suspecting anaerobes, so maybe like a really nasty oral infection where you need to cover anaerobes, you can consider it. The other nice added benefit of Clinda is that in strep infections, that should say strep, not step, sorry, and this is maybe why we like it in OB patients who might have a strep infection, is that it has synthesis of certain bacterial toxins that it suppresses. So strep infections can get really nasty because they do produce this toxin that can cause sort of like a systemic inflammatory response. And clindamycin actually suppresses that. So sometimes you'll actually see Clinda used not for its antimicrobial properties, but for its toxin suppression ability. All right, a couple other random things. Linezolid is a bacterial static drug that works by DNA inhibition as well, and it's IV and PO. It's a good option for vancomycin-resistant gram-positive infections. So we talked about Dapto being kind of an alternative for vancomycin-resistant gram-positive infections. Well, this is the other alternative. And this one's nice because you could use it for pulmonary or central nervous system infections where you can't use daptomycin. Linezolid is notoriously incredibly expensive, but one of the nice things is you can use it orally, which can be an advantage. It has a lot of other weird things that happen, like blood dyscrasias. One of the biggest things with linezolid is it is structurally very similar to a monoamine oxidase inhibitors, which are an old class of antidepressants that are a really potent class of antidepressants. And the problem with giving linezolid is for a patient who's already on an antidepressant, like any type of antidepressant. So if they're on an SSRI, which are the current mainstay of antidepressants like Zoloft or Celexa or whatever it may be, it's contraindicated. So you may have to adjust somebody's psych meds if you're going to have to start linezolid. And then there's Sinercid, which I'm not going to talk about because it's expensive, IV only, going to be used for really odd cases, and it's going to be an ID restricted option at a lot of places. Okay, so we're adding some stuff here. MRSA, we're adding linezolid, doxycycline, and clindamycin. Pseudomonas, we're adding aminoglycosides. Anaerobes, we're adding clindamycin. And atypicals, we finally got some stuff to put on. Doxycycline and azithromycin both cover atypicals. All right, a couple other things. Fluoroquinolones, we can't, of course, not talk about fluoroquinolones. Probably one of the most popular classes of antibiotics out there. For better or for worse, they seem to be one of the antibiotics out there that just is very prone to resistance. If you look at their patterns over the years, they just have kind of plummeted as far as what they cover. But still some really good uses for them, fortunately. They're pretty broad spectrum agents. Generally, they all have good gram-negative coverage, but they also have some pretty good gram-positive, and they cover atypicals. There's 3 commonly used agents. They're all IV and PO, so transitioning somebody from IV therapy is really easy. A couple of them are dosed once daily, too, which is nice. The popularity of these drugs has made them, I think, historically to be highly resistant in a lot of cases, unfortunately. And that's just the way things go sometimes. When you get a new antibiotic class that seems to be really good, use it a lot, find out that actually the resistance rates are pretty high with it. That becomes a problem. So I think things have kind of pulling back off fluoroquinolones recently, but we still use them in certain situations. Adverse effects, tendon rupture, and hyperglycemia I have on the bottom here. Tendon rupture is something that we really only think about with children and really elderly patients. We don't use it in pregnancy because of this risk. There is a study that looked at developing beagles, the dogs that is, and showed an increased risk of tendon rupture. Now, it hasn't been replicated very well in human trials. There's some case reports and some maybe small groups of evidence that support it, but we generally don't use it in pregnant patients, children, or the elderly. Hyperglycemia is another source of problem with this drug, and it's because it has a tendency to increase people's blood sugars a little bit. So if you're a diabetic patient, it could be a problem. So 3 drugs here, Cipro, Levo, and Moxi. They're all a little bit different, and there's some other ones out there too. There's like ofloxacin, which is used as an eye drop. There's a couple other older floxacins that aren't on the market or used anymore, but these are the 3 mainstays you need to think about. Cipro is pretty much just a gram-negative product with some atypical coverage. It has some pseudomonal coverage, actually. And in fact, our fluoroquinolones are the only drugs that are available orally that cover pseudomonas. So that's an interesting point. If you need something oral for pseudomonal coverage, you're really only looking at these drugs. Cipro would cover a little bit of gram-positive stuff too, like some non-resistant strep and maybe some staph too, but we don't really think about it as a great option for that. Levaquin or levofloxacin is similar to Cipro, but has more gram-positive coverage and extended gram-negative coverage. Levaquin has the pseudomonal coverage as well, but it has a much better gram-negative profile and pretty good gram-positive too. It covers most streps and most staphs that aren't resistant. Now, Moxi is very similar to Levaquin. In fact, a lot of people consider them to be interchangeable. However, it actually has some pretty substantial differences. Strongest gram-positive coverage, and actually probably covers some MRSA. However, we don't really use it much for that. It's the only fluoroquinolone that can cover anaerobes. And the other big difference is it doesn't concentrate well in the urine. So where Cipro and Levo could be used for UTIs or pyelonephritis type situations, Moxi should not be used for that. But Moxi and Levo are both considered interchangeable when it comes to respiratory infections. So when you're treating community-acquired pneumonia, Levaquin and Moxi are both good monotherapy options, but in non-pulmonary, you'd want to consider their differences. All right, sulfa drugs, really just one drug. I think there's been lots of sulfa drugs in the past, but there's really one we use right now. It's sulfamethoxyl trimethoprim, which is Bactrim or Scepter is the brand name. Available IV and PO. Gram-negative coverage substantially with some gram-positive, specifically staph. They have really good staph coverage, but not effective for all strep. So it's interesting. Bactrim is actually pretty effective at covering strep pneumoniae, but not very good at covering like strep pyogenes, the type we'd see on our skin, would lead to skin infections. We don't use Bactrim in pregnancy. Frequency used urinary tract and skin infections, but there's a wide variety of applications to Bactrim, and again, it does cover MRSA, so it's an oral option for MRSA, which is nice. All right, so just to mention these, for highly resistant gram-negative infections, these won't appear on any type of test question, but in case you're curious, because I've talked about resistance. What happens if we blow out our biggest guns and we don't have anything left? We have two drugs, one called colistin, and the other's called chloramphenicol. They're really old drugs that were used, probably 50, 60 years ago as early anti-infectious agents. Now they've been resurrected essentially because we don't really have many other options. If something's carbapenemase producing, there's nothing else that's probably going to cover it. So you have to go with other things at this point. These are pretty toxic drugs, so that's why we don't like them. Colistin has some CNS side effects, lung toxicity. What it does, it works by damaging the bacterial cytoplasmic membrane. Chloramphenicol has some similar side effects, including some hematologic ones as well. It inhibits protein synthesis. So just in case you're curious where we go, these are going to be things that are definitely patients managed by an ID specialist, not by the average person. So just in case you were curious about that. I think it's kind of interesting that we've brought back some of these really old drugs to treat some of these nasty infections. Topical agents, mupirocin, bacitracin. Gram-positive coverage is really all these need. These usually cover pretty good for MRSA, streps, and other non-resistant staphs as well. Urinary tract infection only agents. Two drugs to talk about here. Fosfomycin. Fosfomycin is a one-time dose that causes some cell wall destruction, and it's an option for resistant pathogens. I think fosfomycin is an interesting drug. It's not really prescribed a lot. It's probably because it's kind of expensive, but it's something that if you have somebody who has a lot of allergies or a lot of resistances to different drugs you want to use to treat a urinary tract infection, fosfomycin is something to keep in the back of your mind. Covers gram-positive and gram-negative pathogens. So if you have like a resistant enterococcus, which we see sometimes cause UTIs, that could be an option for that. More commonly, we like to use nitrofurantoin or macrobid. Macrobid is orally taken up. So both of these drugs are pretty much the same thing. You ingest them orally. They're absorbed, but they're essentially excreted so quickly that there's very minimal tissue exposure. So we consider them really just pure urinary tract infection agents. Macrobid inhibits protein synthesis. It has some contraindications, specifically with creatinine clearance less than 60. So if you have an elderly and older patient, you wouldn't generally use this in. If you have a patient with compromised renal function, you wouldn't use it in. The reason is there's twofold. If it accumulates, it can cause neurotoxicity, which is, of course, a problem. The other thing is that if it's not getting to the site of action via the creatinine clearance, flushing it through the urinary tract, then it's really not worth taking at all because it's not going to work. This drug is great for the young, healthy woman, pregnant or not pregnant, but it's great in pregnancy, who doesn't have any renal problems. So, and also not for complicated UTIs. So we wouldn't use this for pyelonephritis. The reason being is it's not going to penetrate the kidneys very well. It's pretty much just going straight through the kidneys. It's going to concentrate some in the bladder, and it's going to work well in the lower urinary tracts. It's really not going to work for a pyelonephritis type picture. And fosfomycin's the same way. These are for lower UTIs, non-pyelonephritis. Although I will say I have seen macrobid used for a pregnant patient for pyelonephritis for an extended course one time. That was based on OB recommendations. So sometimes with pregnancy, you're really limited with UTIs. So you're pretty much looking at macrobid or cephalexin, which is what I was saying are the two preferred empiric therapies anyway nowadays, which is good because your preferred empiric therapies are also ones that work great in pregnant patients. But if you can't get by with macrobid, or if somebody has a pyelonephritis, Katrina's going to talk about this stuff more, but before we get too off track, when you have a pyelonephritis, the problem is you really need good kidney penetration. Beta-lactams, unfortunately, don't get the best kidney penetration. What does is Cipro. And Cipro, even though its coverage of E. coli is weaker than the cephalosporin, is going to get into the kidney better. And where nitrofurantoin really won't get into the kidney much, if at all. So that's where you get the decision making here, where you're like, okay, well, I need to pick something that covers well, but also gets to the site of action properly. And I may have given away one of my cases at the end by saying that. So hopefully you were paying attention. All right, Flagyl or metronidazole is mostly used for anaerobic coverage. It's a GI tract and below type drug. That's how I think about it. Has some miscellaneous coverage, parasites and fungi potentially. Useful for GI infections. So this is a drug that's often combined with cephalosporins or Cipro for intra-abdominal infections. So Flagyl plus ceftriaxone is a good option. Flagyl plus Cipro is an okay option. We like to do Flagyl plus ceftriaxone a little bit more now for treating intra-abdominal infections because ceftriaxone has better E. coli coverage than Cipro. You combine them both with Flagyl, and you get the added anaerobic coverage with them. So orally, we give Flagyl. It covers C. diff as well in the GI tract, so that's a nice benefit or nice use of it as well. IV NPO, disulfiram-like reaction is the biggest thing to think about when it comes to adverse reactions. Alters the metabolism of ethanol, and essentially you end up with kind of an instant like nausea, hangover type sensation. So you shouldn't drink any alcohol while taking Flagyl whatsoever. A couple GI agents not used for systemic infections. There's rifaximin, which is for traveler's diarrhea or hepatic encephalopathy. Sfidaxomycin, which is Difficid, which is another C. diff agent. So now we have 3 C. diff agents. We have Vanco, PO, Flagyl, and Difficid. And usually they're used in not quite that order. Flagyl is usually first line, and then Vanco for other more severe infections, and then Difficid would be reserved for a failure to those therapies. All right, so now that we've covered pretty much every major antibiotic on the market, we're adding a couple things. MRSA, we've got Bactrim to add. Pseudomonas, we're adding Cipro and Levaquin. Anaerobes, we're adding metronidazole. And atypicals, we're adding our fluoroquinolones as a class. So you can see how things break down here. Now, this isn't, of course, going to help you treat any infection that comes up, but it's nice to know what covers what as far as the more specific things. The rest of it, you just kind of got to know. You got to know what covers gram-positives better, what has gram-negatives, and then where you would use some of these tools to kind of add in additional coverage if you need to. Oh, sorry, she's postpartum. I thought she was pregnant. I can't even remember my own cases. Sorry, that changes things a little bit, but you can think about it from both sides of the coin if she's pregnant or not. But she's postpartum, so she's breastfeeding. So you could give her doxycycline in this case. That might be an actually good option for empiric therapy. You could still go down the road of Zithro plus whatever. Fluoroquinolones, could consider that as well. So really any of the options are sort of on the table. For breastfeeding, really, Katrina's, I think, going to talk about breastfeeding implications a little bit more. But my general rule of thumb is you have to look it up every time unless you're really sure about it. And you guys might get really sure about some of this because this is your area of specialty. For me, I get asked a lot of questions about breastfeeding and lactation on a daily basis. And it's hard for me to remember what's what. And a lot of the evidence out there isn't solid. It's not like our recommendations are cut and dry, black and white. It's usually like, well, there's been some evidence to show that this antibiotic excretes into the breast milk a little bit more than this one, so maybe this one's preferred. And usually there's not good evidence to show clinically there's going to be a big impact on the developing fetus. So, in the worst case scenario, what you can think about, can you give it to a kid? You can probably give it in breastfeeding. We know doxycycline we don't give to children, but it's not excreted in breast milk substantially, so we can give it in a breastfeeding patient. And then when it comes to our fluoroquinolones, that would be something too that you could look up and figure out, okay, so Levaquin, Moxie, and maybe you guys could think about that as a little assignment from this. I don't think I mentioned that too much on the slide, so you could look that up and see what is the recommendation of Levaquin or moxifloxacin for community-acquired pneumonia for a lactating patient. Okay. If you want to take some time, go back and review that case, go for it. If something I said doesn't make sense, email me. Let me know if you have further follow-up questions. Case 2. Okay, this one is actually pregnant, 34-year-old in her 3rd trimester, following with your clinic throughout her pregnancy. This is her first pregnancy. She thinks she has a possible UTI. She has had UTIs in the past, not for several years, believes symptoms similar to what she experienced previously. She has dysuria, increased urinary frequency and urgency. She denies fever, flank pain, abdominal pain, malaise, and hematuria. Okay, so some considerations right off the bat. Does this warrant empiric treatment, and what agents would be ideal if it does? So I'll give you a couple minutes or a couple seconds if you want to pause it and think about that. Okay. So if you're thinking about empiric treatment, does this warrant empiric treatment? Absolutely. Pregnant patients, regardless of their symptoms, should be treated for any type of bacteria in their urine. So pregnant patients are actually one of the few exceptions where we always treat asymptomatic bacteriuria. So even if she got a culture, it's positive, and she has no symptoms whatsoever, you'd still treat her empirically. In this case, she actually has symptoms, so you would treat any person in this situation. But because she's pregnant, you really definitely want to treat her. So yes, empiric therapy, absolutely. What about empiric therapy, though? Is this a case where we need to consider pyelonephritis? I think I gave you some information there. Pyelonephritis, you think about involving the kidneys and being maybe more of a systemically involved infection. So having flank pain, abdominal pain, fever would be indicators that's more involved than just your standard lower UTI. So what agents would be ideal? I think I've said this so many times throughout this lecture. This should be, again, hopefully right off the top of your head. Macrobid, macrobid, macrobid. That should be your first line thinking. Macrobid has awesome E. coli coverage. It's like 98% of E. coli strains locally are susceptible. 95 to like 98%, depending on what you look at. The other thing you could do if you didn't want to use macrobid, cephalosporin, cephalexin would be just fine as well. Very safe in pregnancy. So those two would be your two choices, and I wouldn't really think about much else. It's pretty cut and dry there. Okay, but I gave you a part two. So let's say you send your patient home on macrobid, but you send a urine sample to the lab. Because she's pregnant, you want to make sure you're covering it. 2 days after your initial encounter, you get the following sensitivity returning from your microlab, and it looks like this. Sorry, that Bactrim's kind of cut off there, but you can see it's resistant at the bottom. So I'll give you a couple seconds again to pause it and look over this information and make a new plan, or decide maybe, hey, this is okay, I'm not going to change the course. Okay, so do you need to change therapy? Yes, of course. Otherwise, I wouldn't give you this. That's obvious. And the big glaring factor is that nitrofurantoin saying it's resistant. Of course, you need to change therapy here. You notice I didn't put MICs on here. I'm not concerned that you guys know MICs. I'm going to give you breakpoints. If I give you a question like this type of a thing on an exam, this is an information you could expect to see. So you gave macrobid. It's definitely resistant. What are other options? Well, we've got ampicillin and sulbactam are also resistant. Levaquin and Bactrim are also resistant. And this is a pregnant patient. So what can we use in pregnancy? Well, ideally, we like to stick to the beta-lactam group. And cephalosporin is a good choice for a UTI. So this is where it gets a little complicated, potentially, because you see Ceftazidime on there is susceptible. So Ceftazidime is the IV, essential IV version of cephalexin. So what we do is, because we got Ceftazidime but we don't have cephalexin, we just assume that cephalexin's susceptible because Ceftazidime is. And they essentially have the same spectrum of activity. So we can give cephalexin in this case. If you could give cefuroxime or second generation or third generation even if you wanted to, but you have no need to. You know it's susceptible to first generation cephalosporins. Don't give more than you have to. So cephalexin by itself be just fine. The other thing about cephalexin, I'll just say since I'm talking about it right now, is maybe the alternative treatment plan. Cephalexin for skin and soft tissue infections is usually dosed 4 times daily, 3 to 4 times daily. For a standard simple UTI, you can get by with twice daily dosing. So it's pretty convenient actually for just a UTI. If you're treating like a more severe pyelonephritis, I'd probably go with 4 times a day dosing. But for just a lower UTI, twice a day is fine. Okay, that's my lecture. Got some references there. And again, if you have any questions, please let me know. And if you have any other comments or anything like that, I'd be more than happy to answer them via email. So we'll talk again in my next lecture, which is antifungals and antivirals, and I'll be